Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Dr. Jenny Berkovich, board-certified pediatrician and director of education at JOMA. My guest today is Dr. Jody Thomas. It was an episode all about pediatric pain and unique ways, really transformative ways that we approach pain, both as parents, caregivers, as well as providers and clinicians. If you have anybody in your life, whether it's a patient or somebody in your home or your family that has ever had pain, or you've had pain yourself, this is the episode for you. Dr. Jody Thomas is a licensed clinical health psychologist and specialist in pediatric medical illness and trauma. She is internationally known expert in pediatric pain, a sought-after speaker and writer, and has trained medical professionals around the world. She is the founder and CEO of the nonprofit Meg Foundation, and leads a team of world experts in pain, technology, and design on their mission to empower kids and families to manage pain and medical anxiety. As faculty at the Stanford University School of Medicine, she was the founding clinical director of the Packard Pediatric Pain Rehabilitation Center at Stanford. An expert in medical hypnosis, she is also the co-director of curriculum for the National Pediatric Hypnosis Training Institute and the creator of Imagine Action, a self-hypnosis web app produced for Stanford Children's Network. Dr. Thomas was an amazing guest. I learned so much. We covered a lot of ground. I hope you enjoy the episode.
Let's start there. Like how did you get into this field? How did you become interested in pain management?
So as a clinical psychologist, I really started out my first practicum placement in grad school, and back in the old days now, was working in oncology. So I worked with kids with cancer and families dealing with this, and quickly realized that the most difficult part of for them to deal with on a day-to-day basis was pain. Pain from procedures, pain as a side effect of treatment, pain as a part of the disease. And I also realized that in Western medicine, we're pretty bad at pain, actually. And it turns out we're not that great at dealing with it. And so then I got really interested in, okay, so how do we need to look at this differently? And so I started doing things like taking courses at Harvard Continuing Ed around mindfulness, and I started getting trained in hypnosis, which I initially thought sounded completely insane and now realized has this amazing research back and is an incredibly powerful tool. So I started looking at other options. Really, as I say to patients all the time, desperation is an amazing motivator. And when we don't have a great solution, we start looking for other ones. And quickly realizing that most people don't understand that pain is a biological, psychological, and social experience. And when we're able to look at it that way, we open up all sorts of different possibilities for feeling better. And not only relieving suffering now, but also preventing suffering and preventing bad outcomes in the future. And that was really exciting to me. And so now here I am 25 years later, running a nonprofit to educate people on those very things.
When I was practicing as a pediatrician in a hospital, very, very often we would see children and young adults admitted with all sorts of diagnoses, some of them absolutely related to oncology and serious chronic medical conditions, and some of them not. Some of them, they were admitted just for pain. And I felt that despite what I considered to have been very excellent training for myself of how to manage the medical aspects of their diagnoses, I did not have a lot of good tools for pain management. I had some right medications that I kind of kept in my back pocket, not literally, but right as options. And there was long-term pain and breakthrough pain, and what do we give continuously? When do we use a pain pump? But beyond that little box of like medical management of pain, I didn't really have a lot of tools. Do you find that is sort of still true, or are people better at recognizing that it's a little bit more complex than that?
It is so much more true than it should be. And just, you are not alone. So the stats are pretty crazy that if the average number of hours that a medical doctor gets over the course of their training in North America is 7 to 10 hours training on pain. That is it. And when I go into hospital settings now, I ask this question all the time. Like, I'll actually be doing ground rounds for some trainees this Friday, and I'll ask the same question. And no one raises their hand. And to put that in context, veterinarians have to get 150 hours of education on pain for treating animals. And it's really also very likely you were trained in what we would say is the biomedical model, that pain is a result of tissue damage, and we must, fix the tissue damage and then pain gets better. Even though the last 40 years of research would say that is unbelievably untrue. That's not how it works. And what it does is it tends to do exactly what you're describing, which is sort of tie the hands of really good doctors. Be like, how do I handle this? How do we do this? So you're definitely not alone. There is shifts, there's a reason people are interested in having me come talk to them and train their trainees. But that is not happening quick enough. And part of our mission at the foundation is to be able to empower pediatricians, because you are the place where kids and families really have their early pain experiences and learn how to think about and deal with pain. And so in hospital-based work, it's great, but we're kind of cleaning up a lack of learning before, as opposed to being like, hey, if we just thought about this way from the beginning, things could be a lot easier.
One of the things you mentioned in the beginning, I don't remember if it was before we officially started the podcast or just kind of our unofficial chat, but I mentioned to you it's important for me to sort of like have the context of prevention when we have this conversation. And you said oftentimes, right, that the patients that you see, right, the ones that are really severe and need a lot of intervention, oftentimes would not have necessarily had to be there if they got the proper intervention. Let's elaborate on that. Tell me, like, what does that mean? Could we have prevented some pain from developing?
Absolutely. So that happens kind of on several different levels. One, there's a straight up of really doing appropriate pain management for even babies and kids and the damage that does. So, one of my inspirations for founding the nonprofit that I did was my daughter was born at 33 weeks. And so she was a preemie baby and in the NICU. And I'd spent my career working in places like the NICU. It was very different being on the other side of the bed, right? And when I was in there, and I'm in a brilliant world-class hospital, I am at that point the head of a major pain program at Stanford. And I was having to fight for what would be very basic care. So we know that when we do medical procedures on newborns and particularly preemies, without good pain management, we damage their not yet fully cooked neurological systems. And we put them at risk for chronic pain, anxiety, depression, increased pain sensitivity, all sorts of bad outcomes for the rest of their lives. And the really insane part is that the pain management is not hard. So I have this picture in my head of standing there with a tech who came in to do a heel stick on my daughter and to do
Super common procedure, right? We do this in babies in the nursery. We do it in outpatient
all the
newborns.
time,
Super duper
right?
common. Yeah.
Super common. And so I said, okay, great. Are you going to let me do you want me to take her out of the isolette and put her to the breast and to do to close? So literally it's holding and breastfeeding. Or do you want me to get a glucose pacifier, literally a pacifier dipped in sugar water, and have her suck on that while you're doing the procedure, a little bit before and during the procedure. And bizarrely, those two interventions can prevent all those negative things. And this has been studied over and over,
Wow.
over again, because it's so mind blowing that a very simple thing, the release of oxytocin, right, can prevent that damage to the nervous system. And that guy looked at me and he goes, "Oh, we don't do that here." And I was like, "Well, we do now." And I said, "Look," he goes, "Well, I don't think you understand." And I said, "Look, I mean this with the utmost respect. Someone in this situation doesn't understand, and it's not me. Like, I understand that you probably don't have the training or protocols or this to be able to do this way. And believe me, by the end of the day, I'm going to have a whole series of conversations about this with people who are higher up the food chain. But I cannot let what you don't know damage and hurt my kid. And I'm not going to let that happen. So either you can go to glucose pacifier or I will hold her the breast. But either
And
way,
these are not major interventions, right? To your point, we're not asking for like an additional body in the room or using a different type of needle or
or
like
yeah,
the procedural aspect of it has not changed.
no, it's not changed. And it just needs, me to be there. And I said, look,
Yeah.
I run a team. I don't want to mess up your workflow. I will be here when you want me to be here. I'm here 23 hours a day. I will be here 24. I don't care. But we're going to do this. And it was really knowing that I obviously do not love my baby any more than the other moms in that
Right.
NICU love their babies. I just knew that there was something to fight for and how to fight for it and how to ask for it and what should be basics. So that's one of those examples of, if we were able to do better standards of care with preemies, we would prevent a lot of stuff down the road. That's at a very physiological level, right? But then we know that early pain experiences like vaccines, which are super common. So if we're just even on procedural pain, that early pain experiences doing those without proper pain management, we create avoidance of healthcare. We create fear of doctors. We create those people that come in and, the kids who are in tears in the parking lot coming to the pediatricians. And what we want is for them too. So the numbers there are also staggering. So 63% of kids, 50% of teenagers, and 1 in 4 adults will make a medical choice based on the fear of a needle than on best practice and what's being recommended by their provider. And that has outcomes
Wow.
in the immediate, that has outcomes down the road when those kids get better, when we're holding down kids for medical procedures, which is the number one thing that should not happen. Everyone's like, well, we have to get this done. I said, yeah, so what happens when they're 12? What happens when they're 16? What happens when they are able to fight back, quote unquote? What happens when they become that adult that all of us know, like right now, if you think, and the people listening think they have that adult in their world that quote unquote doesn't do doctors, right? They can't get them to go get that mold checked out, get that thing checked out because they don't do doctors. They don't do doctors because of things that happened when they were a child. And that there are easy, preventable ways for that never to happen. Because my goal is that those kids feel empowered, that I want them to come in to see you and feel like this is a collaboration and you are there to help them be healthy and strong throughout their lives. And that this is an empowering experience. And we never want those early pain of procedure experiences to create that fear and to create that issue. And then let alone when we're thinking about things like stomach aches and headaches and those things, a third of kids have chronic pain as children. And when we're not giving them that tools of context, we're not understanding and educating kids and families on the fact that pain is a biological experience, it's a psychological experience, and it's a social experience. And that's not weird. That's not crazy. That's not blaming the parent. That's not the
And
kid.
it's real, right? That's I think the other thing that we struggle with is that because we don't see it on somebody else, it becomes very subjective in describing, in assessing and really determining how it's responding to treatment. And I think that adds an additional layer from from the clinician, certainly from the pediatrician standpoint, when oftentimes our patients don't even have the vocabulary, right, to describe their pain.
Absolutely. It is a huge issue. Like one of the phrases that is used within the pain world and with like the big definitions of pain with like the International Association of Pain and all of that is pain is what the kid says it is or the patient says it is. But that feels hard. It's harder if you're like,
Mhm.
okay, am I supposed to give them these strong pain medications or not? Versus, okay, well, what are the various different ways we can bring comfort and we can create a better experience outside of just meds? Because that's what becomes very frightening, I think, as providers is are we, what's going on? And am I doing anything by giving this kid pain medication or giving that message that this is the only way, especially when it comes to things like chronic pain? So it's really difficult. That's why we think educating providers to give them the tools they need. Like that's what we want is to give people the tools and resources they need to provide the kind of care that they want to provide when their hands are tied.
I want to go back to the scenario that, again, super common scenario that you described, probably happening many, many times a day in every single doctor's office that's seeing kids,
Yeah.
is holding kids down for procedures, whether that's vaccines, whether that's blood work, whether that's even like a simple throat swab, right? Or a nasal swab. So I think clinicians and certainly pediatricians love the idea of like, let's empower the child. Like I also like, right, nobody wants to hold down a screaming kid. Doesn't feel good. Sometimes it's scary and dangerous even to the staff, right? When you're dealing with a bigger kid. But practically speaking, right, let's say you're at a busy clinic and you have other patients waiting and you don't have time to like negotiate and discuss and get a child on board. So what are some tools that we can use to avoid that holding child down scenario, but something that's actually going to be, practical during a busy day in the office?
Oh, you and I are on the same page. To me, if it doesn't actually fit into a workflow, then it's not a useful tool. So we have to make that work within like the actual logistics of life and in practice. So it's actually one of the reasons. So really what we want to be using is what's called comfort positioning. So that difference between holding a kid down on their back, which is the most terrifying place we can put.
Mhm.
The research also on there is, we have the recommendations for various pain management strategies, but there's also what is the absolute counter. And we know that holding a kid down, particularly on their back, is a recipe for medical trauma. And you're like, well, we had to do it. You're like, yeah. And you're also buying yourself a lot more difficulty the next time that kid comes in, right? This were the last time we're going to have to do it, maybe, but it's not. That
And
said,
by the way, I just sorry to interrupt. I'm just thinking anybody that's like skeptical that this is they're like probably thinking, I don't know, I'm assuming skeptics out there are like, well, does it really? Everyone gets these and it's fine and we don't develop medical trauma later on. I will say that anyone who is skeptical that this is true has never had to examine a baby on a flat table, right, in the office. Because what will happen an overwhelming majority of the time is when I go to examine a baby just to lay them flat on the table, they will start crying.
yeah.
And I know it's because that's the table that last time they got pokies on.
Yeah.
So my general language is like, no pokies today, no pokies today. But right, whatever their baby, it's too late. Right, the damage has been
Such
done.
a visceral reaction,
Yeah,
right?
it
There-
totally is, and it's real and it's valid, and we see it all the time. And so just to like kind of reinforce that this very, very much happens, and it's not some like small percentage of kids that are affected by these
Yeah,
procedures.
absolutely not. I wish it were. I mean, honestly, say we're like, well, does it really matter if they have a rough few minutes in the doctor's office? I'm like, it does, because it's not just
Yeah.
about those rough few minutes. It's about everything that happens next. And we are primarily just putting that association together in ways we don't want to. And so when we use things like comfort positioning and we have other pain management that we can offer, then we've totally changed that dynamic. And even the language that we use as providers and as parents changes what that's like, because it's terrifying. Often when I'll train docs, I'll actually have them go and lay on the floor on their back and just sit there and notice what that feels like. And that primal response you have there to want to protect your front. You want to turn over and get in a fetal position. You want to put your arms across your chest. And I'm like, look, you're having this urge and no one is coming at you with the needle. You
Right.
have every bit of power in this room. You could stand up. You don't have to do this. I'm just asking you. So, and you're having that feeling. So, what it's like for a child, but it's really different. So comfort positioning, and we have various guides that are open source. So everything, by the way, that the Meg Foundation does is open source and free to use, and anyone can use it. There's a provider kit for providers who are interested, and it tells how we can incorporate it into your practice and how that can fit into workflows. But giving that from the beginning. So when you're sitting here being like, hey, you check in, hey, by the way, there are some ways that, your kid's going to need a pokey today. And I love you using poke. Such a great word. It's a beautiful.
Sometimes I use pointy kiss. Is that false advertising?
That's hilarious. I've not heard it. I love it. But it's really taking away the association of needle and shot.
Mhm.
Both just have very visceral reactions to people, right? And being able to offer different things. So it's also different when you're like, hey, because basically it's like you have to get a shot, you have to suck it up, is like that
Yeah.
message, as opposed to, hey, we're going to get a pokey today. There are all these different ways we have to make you feel better. Okay, we're going to offer you a lot of different ways. And one of those is moms using themselves and dads using themselves to be able to, it's very different to sit here and say like, well, we need the kid to be still. And of course we do. Safety is paramount. We want that provider to be safe. We want that kid to be safe. And that's different when we sit here and have kids being held like straddling their parents, hugged, and being where when I'm like, hey, mom's going to use her arms to help your arm be still while we get this done, is very different than we're going to hold you down if you can't stay still, and we're going to restrain you.
Right.
And that difference, and with, starting out with those infants who can be breastfeeding during that poke, who absolutely should be held during those pokes, because the mere being presence and warmth, and we automatically mirror our parents' heartbeat and their breath. One of the most important factors we can is helping parents center and calm themselves. Because the biggest predictor of a kid's distress is the parent's distress. And parents would be like, well, you'd blame me? I'm like, absolutely not. I'm congratulating you on having an attached, lovely child. But what I want you to do is see your power in that situation. That the thought of calming ourselves down, of slowing our own breathing down, of us feeling settled is a lot easier than somehow magically jumping into your child's head and trying to do that for them. But knowing that when we go in, and that's, by the way, the same for providers. It's one more thing. I'm like, when we take that moment to take our own breath and to intentionally slow our breathing, we're changing the temperature of that room too. But comfort positioning, when we can send it, that's why everything we do is digital. So it could be sent to parents before, being like, hey, here's all these ways that you can hold your child for different medical procedures. Why don't you practice a few of them at home? And we will have a guide there in the room when you come, and then we can give some guidance on how to do that. So you can feel empowered. We can make sure that you and your kid are safe, and we can make sure that providers are safe, and we can get this very important thing done. So it's really about having these different ways. And by the way, comfort positioning doesn't run out, as you would say. So, I
You
have
don't have to keep reordering it, right? You don't have to add it to the budget.
exactly. And
Right.
it also, age-wise, we don't age out. We don't age out of having physical touch and physical connection be comforting. And so there are times, so it's really interesting. Between 10 and 12 is when parents and providers start losing patience with kids. And that's where
Mm-hmm.
shame starts coming in. You're like, you're too old for this. You should be able to
Mm-hmm.
handle this. You should be able to do it. When really, again, we don't age out of trauma. We don't age out of fear. And really knowing that, yeah, having that 12-year-old sit there and sit with mom or sit with dad and have them help. Dad's going to help your body be still so we can get this done. Because you know that your actual real 12-year-old self wants to do this and get it done. But that primal fear comes in. So what we're trying to figure out is how we can calm down that fear so we can get done what you want to get done, and you can be in control. So I say, I'm like, I want you to be making the decisions and not anxiety or fear to be making that decision for you.
I love that. I want to switch gears a little bit and talk. So we covered some preventative things to do. Let's talk about some ways of intervention.
Mhm.
What are some tools, techniques, tips of pain? Let's do chronic pain management, because I think that's one, at least I think as pediatricians we're seeing a lot more of that. We're
Yeah.
all right a little bit frustrated and stumped by. Non-medical, right? Non-medicinal, sort of like non-traditional ways of thinking about chronic pain that we maybe aren't.
Well, the first thing we want to do is that everyone, and to normalize that, everyone being on the same page, that really introducing the biopsychosocial model of pain, which of course, the moment we say biopsychosocial, everyone stops listening because that's a big, long word. So to do that, we actually, so like at the foundation, we've been experimenting with different ways of communicating that. And we have a really phenomenal, actually handout for kids and families called Understanding Pain. And we're a big believer in visual imagery and visual metaphors, because that's how we really absorb and learn information. And so we think of that model and present that model as a three-headed dragon. Okay. And in order to tame the beast, we got to tame all three heads. And that's not weird. It's not bizarre, because again, when we start bringing up psychological aspects, that's where we tend to elicit that defensiveness, right? From families and kids being, well, I'm not crazy. It's just not all in my head. And I'm like, no, I don't think you're crazy. That I think you're human. And this is how pain works in humans. And this is how it works. But we, in the pain program, when I was running that, it was always the first thing we had to undo. That, as I tell people, there's a reason that a psychologist is the head of almost every major pain program in the country. Okay. I was a psychologist heading the Stanford rehab program. And that's because the psychological aspects are so going to be important. So just normalizing that. I mean, one of the reasons that we created some of these tools was so when you start bringing that up with the family, they're like, no, 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 there's something real going on. I'm like, of course there's something real going on. Every bit is real. And one of the classic examples that see people resonate with, I said, look, have you ever noticed that when you stub your toe when you're in a bad mood, it hurts worse than when you stub your toe when you're in a good mood? And everyone's like, oh my gosh, yes, I totally. And you're like, yes, exactly. So our psychological state impacts how our body is processing pain. And that's not weird. That's not crazy. That's not nuts. It's literally how the human body is designed. It's why in the next 6 weeks, we're sitting here at the beginning of September, every pediatrician's office in this country is going to start seeing more referrals for stomach aches and headaches.
Yep.
Well,
Guaranteed. Yep.
schools started, right? The stressors have begun, and that impacts kids. And that does not mean you have a bunch of kids running around who are trying to fake a stomach ache to get out of school. Okay. It means they are literally having more stomach aches. The gut and the brain could not be more closely tied, right?
And I do think it's one of the more, again, just like one of the more challenging things about it, right? That is subjective and we can't see it. And I often will have parents tell me like, I know nothing's wrong. It's just for attention, or she's just stressed about school. And to me, like both of those things are still like there's still a pathology to it, right? That the pain is real. So I always have to like re-educate, like the pain is real. The pain is there, whether it's for attention or as a result of being anxious about something, the pain is still there.
The pain is a message that is telling us something important. We have to figure out what that message is, right? And it is real and they are experiencing. And there is a shockingly few amount of kids who are truly faking pain in the world, even though that tends to be where adults go a lot. You're like, oh, they're just exaggerating, or oh, it's just this. And you're like, no, that's their experience. And if we're not going to deal with that, we're going to create a lot more problems and those symptoms are going to escalate. So it is
Yeah.
a really big problem. So that first part is that education. Do we actually understand that all of these factors are there and all these factors are real? Because in that becomes this very empowering message of, or I mean, that what you just said is so interesting. It just stressed about school. I'm like, yes, do we know amount of diseases and things in the world come from stress? So yes, actually learning how to manage that stress, to identify what those stressors are, to figure out ones that we actually do need to change what's going on in the school environment in order to make that less stressful. And then what is it about increasing kids' coping skills so that level of stress is not physically impacting their bodies and that they are not experiencing this every day? Because that's where we see kids like are going to become higher risk for chronic pain as adults. And that's number one, what we want to prevent as people who take care of kids is that, last year, chronic pain became the biggest strain on our healthcare system in this country. It has now exceeded heart disease, cancer, and diabetes. Not an awesome accomplishment. Okay. We do not want this. But the answer to that is lying in childhood. And when we're sitting here and being like, great, you know what? We are having stomach aches. I want to talk to you about all the different ways. We are probably going to do a little bit of a workup to figure out if some of the common things can be ruled out. But even if none of those tests find anything, that doesn't mean there's nothing wrong.
Right.
It means we have something else to deal with, right? Chronic pain, when it becomes ongoing, the pain itself is the disease. Okay. That process, and that's where our brains and bodies can get trapped in pain cycles even when there isn't a physical, when there isn't a like tissue damage issue going on. And we want to prevent that. We want to prevent that negative neuroplasticity from happening. So when we're talking about the fact that no matter if you had a ulcer in your belly or if this is a manifestation of stress in your body, learning about self-regulation, learning about breathing. Several years ago, I developed a product for Stanford Children's Health that is, again, publicly available, and we have tens of thousands of users every month, called Imagine Action, which is about the common issues around particularly hospitalized kids, but it's really for anyone on acute pain, chronic pain, relaxation, stress. And it's recordings. It's really self-hypnosis for kids. And that's really you're like, I want you to take a look at this and listen to these and see how that changes how your body is doing. And being able to introduce, and we're going to also, let's cut out dairy for a while, or whatever the things that you as provider know could be contributing. But we are coming in from the beginning being like, and mom, the first thing we're going to say is we're going to stop asking about the kid's pains. When a kid enters a chronic pain program, the first intervention we have for parents is to stop asking about pain. And that trusting that child will bring that up. But when, we get what we focus on is the general rule in life. And it certainly is with pain. And pain is a product of attention and focus. And if we are constantly talking about it, we are in fact then redirecting back to that experience. And so if we start off every morning asking our kid, how's your pain this morning? We have literally asked them to refocus their attention on the negative aspects of their experience. And we're like, nope, we're not going to ask about pain anymore. And it doesn't mean we're ignoring it. It doesn't mean we're invalidating it. It doesn't mean any of that. It means we're going to bring this off the focus of attention. As I tell kids when they come into the program, I would say, look, right now, if your life were a newspaper, pain would be the headline on the front page. And I have only known you for a little while, and I already know there are much more interesting things about you and your existence and all the things in your life. So our goal is going to be making pain be like a third or fourth page story, and we're going to figure out what actually goes on the front page, because it's not very fun for you to have pain be the headline news, is it? And they're like, no. I'm like, great. And that's not about it not being anything. So this is where we recently, it's just also a great resource for families, but also for other providers. We recently did a collaboration with the Society for Pediatric Psychology, which is part of the American Psychological Association, their pain section on which are family education sheets on pain, chronic pain in school. Why should we be talking about going to school when we're having stomach aches every day? And you're like, actually, turns out finding ways to be in school is going to be important to that recovery. Why pain and CBT, cognitive behavioral therapy. Why is my doctor talking to me about going to a psychologist when I keep on having headaches? And you're like, well, let me tell you. Pain and functioning. Why is it important that we keep on doing our daily life when we have chronic pain? And because not doing it actually worsens pain. And that all those aren't about, I don't believe you. I very much believe you. But I do know that these things are going to be so important to you being able to get better and learning to cope and learning to deal. And learning to cope is actually what's going to make you feel better and get you back to the place that you want to be. But those are tough sells for families, right? To say, look, I still want you going to school, even when you have a stomach ache. Because people are like, well, I don't believe you. No, I very much believe you. I mean, kids would say this to me in the program all the time. And we had, so like a chronic pain rehab program like mine, we had kids were with us to 6 to 8 hours a day. They had 4 hours a day of OT and PT, occupational therapy and physical therapy. They went to the hospital school. They had an hour of psychotherapy. They had parent coaching, family therapy. And that was because it was about reorganizing their lives to stop it be really about the pain, but how are we getting back to normal life? And how's everyone having the tools and coping tools to be able to do that successfully?
So on one hand, you are trying to focus on the pain. You want it to not really be like the headline. But on the other hand, that's like a lot of effort
Mm-hmm.
to put into giving them tools to deal with the pain.
Absolutely. Yes. And that's where the balance is. It's interesting that the number one thing that we got pushback from when families would come into the pain program was family therapy and parent coaching. They're like, well, you don't need that. And I said, you do. And again, that's not a knock about you. That's not, I think you're doing something wrong. And that's why we created a book. It's available as an ebook on the website called Myths and Facts Around Pain, and goes to all the really common misconceptions around pain, right? And one of them is it's the parents' fault that kids have chronic pain, right? And you're like, no, it's not the parents' fault. That said, parenting a kid with chronic pain takes a very particular skill set. Right. So it's not about it being your fault, but it is about learning ways of having to interact and deal with it to create that balance that's difficult. Now parents sit there and say to me like, well, I should know how to handle this. I'm like, Should you? That'd be weird, right? You didn't have a
Right.
baby and sit there and look at it and be like, you know what? I wonder if they're going to have chronic migraine headaches when they're 10. You're like, of course you don't know. And that's okay. We just need to recognize that learning some new skills can be incredibly helpful for reducing the burden off you as a parent and off your child and really open up pathways for you, everyone feeling better.
What are some tools that parents can use at home? Let's say not necessarily someone who has pain that's severe enough, like to right qualify for a whole program, but let's say we have a kid who has ongoing tummy aches, ongoing headaches, and um, from a medical standpoint, we've ruled out some organic causes, right? So the pain is real. We know it's there, but there's nothing organic, right? We know it's not celiac. We know it's not, for example, migraines, right? They're functional, which is not a diagnosis that anybody likes, but ultimately a very common one, like functional pain. What are some tools that parents and families can use at home?
So, a lot of the tools are going to be engaging and helping with kids to, again, normalize and understand um, that what's going on in them, their stress, and things like sleep, nutrition, exercise, and stress are going to impact this. And not as that as an accusation, right? That, like, well, it's just stress about school. You're like, no, no, that's a big deal, right?
Right.
And when we start doing things like recognizing, particularly if kids are on the younger side, is, we're going to take a few minutes and just do some breathing together. And there's a million apps that are good for that. There's videos, we've got some stuff on our site. And to be like, we're going to see and notice what it's like to sit there. And if we just take 5 or 10 minutes and breathe, how does that change how our body feels? Right? We are going to come home from school and we're going to intentionally decompress. We're going to make sure that you get a snack so your body's not realizing that some of the really big stressors around things like school are, did you go to the bathroom today and didn't hold it for most of the day?
By the
Um,
way, that the answer overwhelmingly is no, they didn't go to the bathroom.
oh,
And yes, they absolutely held it,
yes,
right? Super common.
absolutely. And then it's put you kids who are neurodiverse in any way, who
Yeah.
aren't good at recognizing their body's own needs, to be like, you know what? One of the best things we can do is go home and we go to the bathroom because that's what we do, not even because, well, I don't have to go to the bathroom. You're like, really? I think your body probably does have to. That when we're taking care of our really basic needs of, we had a snack and we went to the bathroom and oh my gosh, my body feels less stressed. You're like, yeah, because your body was trying to tell you something. And so now that it's less stressed, huh, I bet your belly feels different, doesn't it? Or your head feels different. You're like, yeah, I do. Okay, great. What an amazing thing you figured out about how your body works. But that has to be the attitude, not see if you just go to the bathroom, this would be better.
I told you you would feel
I
better,
told
right?
you it would be. You're like, no, you're like, what a cool thing we've learned. Okay, great. So we're going to have a snack. And we've learned that if we actually eat the sugary snack or whatever, and it's not about sugar being bad. It's like, how does it impact your body? One of the things we can do, especially around abdominal pain, is for kids to get that relationship between what they put in their body impacts how their body feels. Not in a sugar is bad or this is bad or things are bad, but more like, hey, when I do this, this is my body feels differently. You know
And
what?
I want to just recognize that we're asking for a lot, right?
Ah,
This is a lot of work. I say it a lot on the podcast. Like these are great tools, and I love the concept of mindfulness. And certainly, like for school age kids, it's something that we want to enforce and empower. But it's not easy. So any parent or like caregiver, right, who's listening, being like, "Wait,
yes.
what? Hold on, that's a lot of work." Right? It's a lot of
It's
work.
a lot of work, yes. And what I do in order to help parents with that is I'm like, pick one. Okay. I don't want you to try to do, we're going to use like imagine action and we're going to have you listen to this and we're going to do all
And
your
we're gonna do the breathing, and we're gonna do
this,
the
and we're going
magnesium
to this,
gummies,
and we're
right?
going to talk about this, and we're going to work on homework. I'm like, no,
Right.
we're not going to. That signing up for too much at once is a recipe for failure and a recipe for stress. And to say, like, look, we're going to do this one thing first. We're going to come home, we're going to pee, we're going to eat a snack, and we're going to breathe. And that will take 15 minutes if we do it right. Okay. And we're going to coach that. We're a working parent and we're not doing that yet. And so we're going to do that when we get home. And we're going to do it before bed, where we're going to go and just lay in bed and breathe together, or we're going to put on the Calm app or the Sleepiest app or Imagine Action or whatever it is. And you're going to find the thing that works for you. But the biggest thing is we want to normalize the fact that what's going on around us and what's going on in our brain is going to impact how we feel. And that's not scary and bad, that is empowering. So we get to be curious about it. And so that's the number one thing when I say, what do I want you want me to do? I said, I want you to be curious. And I want you to sit here and wonder, and that all of this is going to be kind of, it's an experiment. We're going to figure out when we make changes, and we're going to pay attention to the data about what happens. And it turns out when we did this every day, I felt better. Fantastic. Let's do more of that. You're like, well, I did that every day and that didn't help at all. Okay, great. Let's move on to the next thing, because it's not going to be an A plus B equals C every time. So we get to be curious, and we get to figure out what works with your family and with your life and what that's like. That I'm not ever going to tell you have to reorganize your entire existence around this, because that's never going to work. It has to be what fits for you.
And it's dynamic, right? And the whole concept is like still experimental in the sense like right, not the concept really, but like the way that you approach it, right? In your family, you're just gathering information, right? You're getting data points and you're adjusting as you learn more. So some things may work, some things may not, and that's the idea. I think that I really want to reinforce of using some of this and really being not as hard on yourself, because I find parents and caregivers really are hard on themselves, right? When we try to make any sort of changes
100%.
with children.
Well, and kids with chronic pain are more likely to be perfectionistic and anxious. Um, that's just the way the profile is, which usually means that you're going to have a parent who's more perfectionistic and anxious. And again, like
Yeah.
kettle black. I mean, this is most successful people in the universe. So I laugh when people like, well, I can't believe I'm obsessive. And especially when I was at Stanford, I would laugh. I'm like, hi, welcome to Stanford, home of obsessive people. Like, we don't get to do many successful things in our world without being a little obsessive and anxious. And I tell kids, I'm like, I want you to figure out how we funnel your power, your that tendency for the powers of good instead of the powers of evil. Okay. We want you feeling good. And we're going to figure out how to do that. It's not about never being stressed. It's about how are we focusing that? How are we dealing with it? And what direction is that going?
I want to end by asking what are some realistic expectations in terms of how long this takes? Chronic pain is chronic. And so it's been there for a long time, at least 6 months, and by most definitions
By
of pain.
definition, yes.
Right? And so what should we expect in terms of timeline of how long it's going to get to be pain-free? Or maybe should that even be the goal? Should the goal be pain-free?
Well, that is an excellent, excellent, excellent question. First of all, it's going to be all over the map. It's really going to determine what's going on, what's ongoing stressors, what the nature of things are, what the illness is, all of that. That said, we do need to let go of the concept of pain-free being the goal.
Mm.
Okay. That is a dangerous game, and it's a dangerous thing that we put into the common culture. And the fact is, we want things to be manageable. We want to be able to have ways of making ourselves comfortable and be able to function and do well. But it's one of the ideas of like why people have more addiction risk after surgery, and we think we should be pain-free after that. And you're like, actually, that's your body. Reprogram that to that's your body healing and doing exactly what it should to be able to heal and get better. And so we want to give you enough pain medication so it's tolerable, but actually pain-free is not the goal. And when it comes to chronic pain, it can't be, one of the most dangerous ideas is I can't function until my pain is gone. And the truth is, your pain is never going to be gone until you function. And so that goal isn't, I want it to be pain free right now. It is, I want to figure out how I keep on living my life and getting better and better and doing more and more of the things that I want to do and be doing the things every day that I want. And eventually that pain will go away. That primary goal of getting back to the life and existence, including your life as a parent and as a family, that's the better goal, because that part has to come before actually that pain is going to go away, which is a very unfair reality. And I wish that weren't true. And I think we have to recognize that for parents all the time. You're like, look, I wish there was a magic pill. That would be amazing if there was. But people are more complicated like that, more than that. Brains are more complicated, bodies are. So we know that it's going to be all of those things. But pain also doesn't necessarily mean. So one very important idea that parents and kids have to get, particularly when it comes with chronic pain, is the difference between hurt and harm. Primal urge to avoid pain is it's a signal that something is wrong, right? We touch a hot stove, we pull it away because we're going to harm our bodies if we don't. We step on that Lego, it hurts so badly, we need to get our foot off the Lego. But with chronic pain, particularly like functional abdominal pain, like that, there's no harm coming to our body. It is bothersome, it's a problem, it's an issue, it hurts, but we're not actually being harmed. And being to separate those two out, like if you break your ankle and you keep walking on it, you're going to damage your body. And we don't want you to do that. So we need to put it in the cast, do the thing. But if your stomach is bothering you going to school is actually going to be a part of it getting better, not something that's going to continue to harm you. That being able to, and that's where a lot of the parental anxiety comes from, is, am I harming my kid? Am I ignoring something that I should pay attention to? And until we can sit there and feel safe in the fact that, yeah, my kid doesn't have an ulcer, my kid doesn't have a tumor, my kid doesn't have celiac disease that we should be cutting out their diet. And once we do, instead of that being like, oh, there's nothing wrong, be like, great, now we know that their bodies aren't being harmed by this, then it's going to be a matter of focusing on how we manage and deal with the pain, as opposed to thinking there's something frightening and scary and threatening underlying it. And that hurt versus harm. Okay, so that hurts you, but the good news, it's not harming you. So now we got to figure out how we just cope with that signal as opposed to coping with whatever scary, harming thing is below it. But that differentiation gives people a framework that's very, very different to be like hurt or harm. And turns out, okay, so this is just hurting, but it's not harming me. Great. Now we can learn to dissociate from the pain, to ignore it, to function through it, and recognize how our body will start just normalizing it. And then we don't notice that pain. That distraction, being the one of the more powerful things we can do, doesn't invalidate that pain experience at all. It just means you're taking control over it. And we never want to punish a kid for coping well. Like you worked in a hospital setting, and it would happen, I'm sure, all the time, right? Where a kid who's having pain is then watching a show or playing a video game, and then person comes in and is like, well, they can't be in that much pain. Look, they're happily playing that game.
Yep.
And you're like,
That's fine.
no, they're happy. They've managed to distract themselves and to refocus their attention on something else. They need to be congratulated for that, rather than being like, oh, where their pain must not be that bad. And
Yeah.
like, well, actually, they've refocused their attention and actually gotten and found a really good way to cope with that. That is a brilliant coping skill, not an invalidation of their actual experience.
I love that approach. And again, just want to re-emphasize that this distinction between hurt and harm, I think, is critical to how we approach children with pain of any kind, by the way, but certainly not something that's easy, right? And I think it's challenging, but very, very worthwhile part of the process.
Yeah. And that's why we created all of the resources that we have on the website to support parents, to support providers, to be able to have that, as these are big concepts. For most people, this is a transformation in how they've thought about pain and kids. And that's what we want them to have, that because it's so much more empowering as a parent and so much less scary, right? Less
Yeah.
terrifying.
I love that.
And that's
I
what
love that. Dr. Thomas, I want to thank you so much for your time. This was an amazing episode. I'm going to add information about the MEC Foundation and all the wonderful resources that you mentioned. We'll add them in our show notes. And thanks so much.
Thank you so much for having me here.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.